Good afternoon, everyone. So we're really going to pivot from all this relaxing and sort of very, very, good energy, but we're going to wake up a little bit to talk a little bit more about cancer and why all this is so important to all of us while we're here. I really want to start off by thanking Sarah and her amazing team. I think one of the interviews that Isaac did, he asked me what I love about Total Health Conferencing. And obviously, besides the fact that Sarah is a powerhouse, she makes her and her team, and they're not in this room, but they just make everything look so easy, which is just how great they are, because all of this is so difficult in keeping it running smoothly with smiles on their faces. And really loved the outing last night. So really appreciated you thinking of that. So without further ado, I'll just get right into what I want to talk about. So thank you for giving me the opportunity. So I'm Shayma Kazmi, thoracic medical oncology at Penn Medicine. And we're going to talk about next generation sequencing and liquid biopsies. These are my disclosures. So really a mishmash of an agenda. I really wanted to go back and highlight the current indications for use in NGS and lung and other I say other cancers because it's really not as well defined in some of the other solid tumors as well as it has been in lung cancers. So I think lung cancers have been in the forefront of that paradigm, and I think it's really important to start with talking about those and the variety of biomarkers that we know a lot about, the ones that are emerging and their treatments, the types of biopsies that we're now grappling with in trying to decide which one's best for our patients, and the differences between these, and then, of course, what the future holds for these is just a dream, right? I'm going to start off with the NCCN guidelines. These are not new. I know this says here February 2022, but these are many years old. I would want to say, I think, about 5-6 years old. And it's really important to highlight that for stage 3 and 4 advanced non-small cell lung cancers, after establishing histological subtype, the next thing really to consider is biomarker testing. And so, of course, for the non-squam, non-small cell lung cancers, biomarker testing is category 1 per NCCN. Not a lot of things are category 1 on NCCN. And of course, they talk about this panel testing right up front, EGFR, ALK, the 7 most common alterations. But they really do recommend that this be conducted as part of a broad molecular profiling test, which doesn't happen even today in a lot of the academic institutions. I think that a lot of the oncologists still consider doing only panel testing. So this is an important thing to be pointed out, and certainly we know about PD-L1 testing. Squamous cell carcinomas, typically these are not ones that we identify as ones that harbor driver mutations, but yet it says here, consider broad molecular profiling. So consider is a word that you have to use with your own judgment. But there are patients who will have squamous cell carcinomas but may never get the benefit of molecular testing. And this ought to be as part of something that we think about, maybe not from the get-go, but eventually down the line. And we'll talk about why that matters. So I came across this, I was looking to see the current rates of genomic testing in the United States, which is hard to find. And so this really great study that was done, it was a retrospective study Dr. Gutierrez did with 90 oncologists in the New Jersey, Maryland area. There were 15 or 16 different centers, including both academic and community oncologies. And they were looking to see the gaps and opportunities in genomic profiling in advanced non-small cell lung cancer. I should say that really all of these patients had non-squamous, non-small cell lung cancer, which is the population we're really talking about initially. So if you look at the study population, the things I'll point out, I don't know if I can use the pointer or I can see what I'm pointing at. Maybe not, I'll just point it out. The patients that were not tested right on the first line. So you can see out of the 814 patients, 41 patients were not tested for EGFR and ALK mutations, frontline. So about 60% were tested. which is shocking to me. Granted, this study was a few years old. I'd like to think that these numbers have improved, but this is sort of the Northeast. This is the United States, where access is certainly much more prevalent than, say, other countries or other rural parts of this country. And so, and then all 7 NCCN mutations were only tested in 8% of the patients. So this was shocking, and it really sort of an important piece in highlighting what we all talk about in these rooms, in academic rooms and in big conferences. What we assume to be the standard of care across the country really isn't. And I'm going to get into why this is so important, the dissemination of information into our community clinics, as well as awareness and making this easy for the local physicians who grapple with this all the time is important. And of course, the types of clinics are listed there. Most of them are community clinics, 75% of them, and the years of diagnoses are listed there. Granted, this was a few years old, and I hope that this has improved since then. You can see the gender was pretty much 50-50, age under 65, over 65 was 50-50, and then really there was no real differences in terms of, most of them are 2/3 were smokers, and most of these patients had adenocarcinomas of the lung, and really they were all non-squamous cancers. Most of the patients were stage 4, some stage 3. So when you look at the things that I talked about, the patients tested for EGFR and ALK, which is sort of really almost rudimentary, I would think, right now today in non-small cell advanced lung cancers, only 60% were tested, and there was really no differences in the patients who were over 65 or under 65 in this testing. Now, genomic profiling rates before first-line therapy. Obviously, we know, and I will look at the data with you, is the patients who have driver mutations who are then treated with that targeted drug do far better in terms of progression-free survival, overall survival than chemotherapy, right? And so really profiling these patients before first-line therapy is essential. And so the total number of patients who had this testing done, again, was only 60%, but the NGS was attempted in 9% of the patients. And so, again, all of the patients had EGFR and ALK, only 8% were tested for some of the other mutations. Now we know that there's much more data today compared to 2015 for some of these other mutations and frontline therapies, and back then it was maybe not as relevant. So I take that with a grain of salt, but this really still highlights the problem. Now, at the first disease progression, the rates improve a little bit. So these are patients who are treated with first-line therapy, and at that time, they were then profiled to see if there were any other treatment options. And these rates improved a little bit at that point, but again, not 100% of patients had this testing, even at time of first progression. So really, why is this important? So we know that overall survival stratified by therapy, patients who have a druggable mutation, if they're treated with targeted therapy, the average median overall survival is upwards of 32 months. Now, this is sort of putting them all together. Certain ones do far better than others, and patients who receive cytotoxic therapy, who had a druggable mutation instead of their targeted therapy, have a much dismal prognosis, 12.7 median overall survival. So the idea that we need to find these targets and treat them if they have these targets is not lost on any one of us. It's how to get there that seems to be the biggest difficulty. Reasons for not testing. I really thought that I would have the aha moment in this table, and really none of the oncologists who filled the survey out really reported the reason for not testing. I mean, I think we know a lot of these, but 52% really just didn't report a reason, and in some of them it was insufficient tissue sample, which we'll talk about, and then rapid death was only in 7% of the patients. So they didn't get into deeply why, but we will in this talk. So why is this really important? We talked a little bit about EGFR and ALK, but as you can see, the explosion of biomarkers, especially as it relates to non-small cell, non-squam lung cancers, is really been important. I mean, it's just like a salad, so to speak, of targetable mutations. And even when I educate my patients about what I'm testing for, when they ask what I'm drawing, if I'm drawing a liquid biopsy, if I'm sending their tissue off for testing, they want to know what I'm testing for, and I explain it. It sounds overwhelming, because my explanation gets longer and longer and longer. At first it was EGFR, then it was EGFR ALK, and now it's everything. It's PD-L1, it's RET, it's MET, it's TRK. There is, now the KRAS G12C is also druggable. So this is so important. This graph just keeps going, and we're making more discoveries every day, but translating these discoveries to these patients who really will benefit is so important. So when you look at lung cancer as a pie, if you look at A, you know that 85% of lung cancers are non-small cell lung cancers, and small cell lung cancer is a very small piece of this pie, and a very difficult one to treat. So I won't get into that a little bit right now, but as far as non-small cell lung cancer histology goes, 78% are the non-squam types, and squamous is about 18-20%. So predominantly lung cancer is the non-squamous subtype, and of those, if you look at the oncogenic mutations, if you just avoid the big purple pie, piece of the pie, which is not identified, look at the percentage. Almost 68% of these patients will have a potentially druggable mutation. And if you have someone in the clinic that is a non-smoker, that rate will be much higher in my head of their likelihood of having a targetable mutation. So really, it behooves us to not be checking every single one of those patients at every opportunity that we can. So the biggest pie is taken by EGFR, but you can see there's BRAF, MET, or B2, which is obviously targetable as well now with trastuzumab deruxtecan, ALK, RET, ROS1, and TRK fusions, which are really hard to find. They're like a needle in a haystack. I think I'm still looking for my first one. But then the KRAS pie is now split into two. The G12C mutation is now targetable. If you look at the squamous cell lung cancers, remember we said that we should consider testing these patients as well. And predominantly it's because really none of these are well-known drivers or have frontline treatment therapies just yet. But these mutations and alterations may play a role in resistance mechanisms, not only in chemotherapy, but certain immunotherapies that we use in these patients, and these can evolve. There are now FGFR mutation targets as well that need to be studied better in this cancer type. PIK3CA alterations are present. We don't know if PIK3CA drugs work in lung cancer the way they do in breast cancers, but there's just so much to learn by doing these analyses that I think that even the squamous cell lung cancer patients should have this opportunity. So as I'm going to sort of keep emphasizing that targeted therapy improves survival, that is really, really, really the take-home point, right? At the end of the day, every single patient that has a disease that may have a targetable drug really needs to be identified because it makes a difference in their survival. And that's really the end game, right, in everything that we do. And so these are currently the plethora of drugs available for the respective mutations, and the list is continuing to grow as not only are patients being treated with these drugs, but now they may be developing resistance to these frontline TKIs, and now there's resistance mechanisms already driving the research towards the next category of drugs that need to be used. So EGFR, ALK, ROS1, BRAF, MET, RET, and NTRK are what's listed in NCCN, but there's also the KRAS G12C that was recently added on with sotorasib being approved in lung cancer, the NRG1 fusions, which are not prime time just yet, but there's a lot of data emerging with afatinib and seribantumab. And HER2 has really taken a spotlight in HER2 low in breast cancer, but we can't forget that there are patients with lung cancer who have HER2 mutations or B2 mutations that do benefit, and this is on the NCCN guidelines with either trastuzumab emtansine as well as trastuzumab deruxtecan. So the age-old question of a standard biopsy and liquid biopsy, of course we still cannot get away from standard biopsies for obvious reasons. We need a histological diagnosis for any patient with any cancer to identify really what kind of cancer they have. I think that technology has not been innovated to the point where we can bypass that. So we do always have a standard biopsy when we have to diagnose a patient. It is time intensive. We know that this is invasive. And sampling of tissue. There's a debate about tumor heterogeneity. Do we biopsy the initial tumor? Do we biopsy the metastatic lesions? Are they different? The tumor may be different in the metastatic lesions. Each of those lesions may have different expressions of markers. And within a tumor mass itself, there's heterogeneity depending on what location you're going after. So there's a lot of heterogeneity, and what we sample in time is what we get. It's static in time, it's static in place. That's a sample we have that sometimes we use 2-3 years later to determine a patient's therapy. So it's something to really think about. Of course, it's not easily obtained. It's not as easy as a breast cancer sample, perhaps. A lot of these patients have smoked. They might be oxygen dependent. Getting a bronchoscopy, putting in a needle, they can have a pneumothorax. There are lots of complications to consider, and what type of tissue you end up getting really determines what kind of testing we're able to do. If they only have a malignant pleural effusion, you're left with a cell block, which then has to be sort of split up for different levels of testing. And obviously pain, risk involved with any invasive technique. Now, liquid biopsy sounds very, very appealing. It's a blood test, so certainly not invasive, but very minimally invasive. These patients get blood tests all the time. And so that's something that is faster, it's quick. It can do comprehensive tissue profiling. I think the technology has really advanced a lot today. Minimal pain and risk and minimally invasive. So what is it actually testing? I know we've talked about liquid biopsies this whole weekend, and I'm sure you know what it is, but really you're looking at cell-free DNA from multiple sources. So it doesn't just come from the tumor, but really it does come, and we may have contamination with CHIP, which is clonal hematopoiesis, and separating out what is contaminant versus what is actually tumor-driven is also part of the technology and the innovation. Now, when do we use liquid biopsies? Now, that answer will vary depending on the clinician you're talking to and depending on what malignancies they treat. There is no standard guideline, really, about when to use this technology. So I generally tend to use it when I know I need molecular testing of a tumor, but certainly the amount of available tissue is inadequate. So if I have a community patient who had an FNA and a bronchoscopy, I know that tissue slide is just inadequate to run what I need to run, which is a full panel testing. So those patients are really ideal to run a liquid biopsy on. And so the initial testing time is a good opportunity, but there's a really great opportunity in testing for patients who may have resistance to first-line targeted therapies. So patients who may have an identified mutation, who have been given a drug to target that mutation, or eventually, it's not a matter of if, it's a matter of when, develop resistance mutations. Now, that is a time point in their disease where a liquid biopsy can be really helpful. Why not biopsy a lesion at the time? Well, besides the obvious downsides of having to do a procedure on a patient, really you have to identify the lesion that is growing. So you really have to capture the one resistance mutation that is actually driving the disease. And patients may not have systemically progressive resistant disease. They may have disease there's only one lesion in the liver that's growing, and all the other lesions are actually responding to the initial therapy, right? And so I have patients with EGFR alteration could be getting treated with osimertinib, and there's one lesion in the liver that's enlarging, and now that lesion may have a MET amplification as a resistance mechanism. So you may not need to change the entire therapy, but you may need to perhaps add a MET agent to combat that specific lesion or radiate it or whatever it is that you need to do. And so in those cases, liquid biopsies can be really, really useful. The only caveat I will say is if the patient has CNS metastases, We have difficulty with ctDNA capture from brain metastases. They're just not that easy, and so you have to be careful with that interpretation. And certainly biopsying the brain isn't easy either. So that's really just an area that is difficult, and we're going to need to do a lot more research. Advantages we talked about, and the limitations. The sensitivity is not 100%. Now, it depends on the amount of tumor the patient has. The patient has widespread metastatic disease. Well, that's really great for capturing ctDNA, not great for the patient. But some patients have really, really sub-centimeter, small, tiny, slow-growing lesions. And I don't know that the ctDNA test would capture a lot of those. And so what's really, really important is that a negative test is not informative. It is not a negative test. And so there are often times when I do consulting for genomic testing, the interpretation of a negative liquid biopsy is, no, they don't have any mutations. And sometimes it's no, you didn't get the answer at all, and you may have to then go for a biopsy because your sensitivity wasn't high enough. The patient had an EGFR mutation, it didn't go away. So if your liquid biopsy didn't capture that mutation, then you just didn't capture enough of the ctDNA from the tumor to give you the answer you were looking for. And so that's really, really important. I don't think it's always highlighted that clearly on these reports that we get, and it's certainly something that they have to work on and making very clear. So this is sort of a little historical timeline for liquid biopsies. I'm always surprised by how long cell-free DNA has been around, and it's just become prime time for us in the last maybe 5-6 years, but it's been around for a long time for multiple different purposes, but it wasn't until really in 2013 the ctDNA was used to track cancer progression, and since then we've sort of taken off. The clinical validation was in 2014, and then since then the technology just has been so much improved that we're starting to have approvals, of course, in using it in a variety of cancers, but also in tracking patients for response. So the solid tumor biopsies, I touched on this a little bit before. Technically, everyone is getting better at their technical biopsies either. Even my pulmonary colleagues who used to just do the FNA and sort of call it a day now knows that all of their biopsies for malignancies need to be utilized for multiple different platforms and testing. Certainly PD-L1 testing can only be done on tumor tissue. It's not available on liquid biopsies. And so there are novel biopsy techniques where they're generating smaller samples with diminished cellularity. Endobronchial ultrasound is great. The EBUS is a great improvement. They do navigational bronchoscopy. And then the issue is that multiple tests with potential for discordant results. So there are often times we may get multiple different biopsies because they're being so good at getting us the sampling from the primary tumor as well as the lymph nodes involved. And you will run tests and you'll find that the primary tumor had a PD-L1 expression of 50%, but the lymph node had a PD-L1 expression of 5%. It's like, which one we're going to go with? And so the tumor heterogeneity is highlighted even more the more sampling you do. And there's a discordance. Certainly if one of those samples has a driver mutation and one of them doesn't, we always opt to treat the patient like they have that driver mutation, and the other test is perhaps not picking it up because of sample error, but we truly don't know. And there are technology-specific failures, of course, and quality assurance of genomic medicine is ongoing. Which test is best? I'm not going to settle that debate here. I think it's region-specific, it's physician-specific, it's cancer center-specific. I mean, I think all of them have benefits, the best test is the one you actually run, right? In my world, that's all I want to sort of impart upon everyone is to run any test that you feel comfortable with because the information is most likely actionable. The logistical issues that we have, of course, return of assay results, it's the biggest pain, right? Patient and families are waiting, looking at us. My loved one has an advanced stage 4 lung cancer. Why are we not treating it? We're waiting. We're waiting for the results, and we're waiting, and sometimes these solid tumor NGS assays can take 2 weeks, and that's 2 weeks of like business days, and then it's like, oh, I maybe just got here and then it wasn't adequate. Sometimes it comes back as QNS, quantity not sufficient, and that's just, it hurts because then you have to face the family and go, oh, now we have to either do another biopsy, and nobody wants to wait. This is a high anxiety time. Patients have a very serious diagnosis. And so this timing, they're getting better, but I think that, 2 weeks is may not seem like a lot to us. It's a lot for these patients. And then desirability of centralized versus local testing approaches. There are lots of academic centers that'll do their own sort of panel testing. The good and bad thing about it is you get the panel, but they may use up the tissue and you have 7 mutation testing, but you wanted to do the full next-gen sequencing, and now you don't have enough tissue to send off for that sequencing. And there's a lot of sort of, there's no real agreement even in the area that I work in the best way to do this. And then, of course, lab and clinical staff and new technologies and their ability to reflex some of these. I just had a meeting with my local hospital to try to reflex some of these advanced non-small cell lung cancers to these testing. And all of the oncologists on the call couldn't agree on which test they would use. And so the pathologists are stuck with how many kits are we going to have in here and how many forms are we going to fill out, and we can't remember who wants which test, so we have to agree on which test to send. So there's a lot of confusion with that as well. And then distillation of high volume data into standardized reports usable by clinicians. This is really a very, very important thing. I spend a lot of time interpreting a lot of this data with physicians who are very busy. They treat a multitude of cancers and really kind of spend time, 35-page reports for Foundation or Garden is brutal. And so, of course, the first 1 or 2 or 3 pages are what's looked at, and you really hope to get what you need out of those pages, but there's so much data buried in the full reports that may be relevant. And I think improving these reports to make it actionable and easy and having access to someone to call a genomicist to really clarify what all this means. And a lot of these companies are doing this now, which is really helpful to help sort out what really is important and actionable and what's just background noise. And then tumor biology, we talked about this, diversity of molecular subgroups, right? Inter-patient heterogeneity, inter-tumor heterogeneity, sampling bias, and then cancer evolution. So we talked about being static in time, doing a biopsy when the patient had cancer a year and a half ago and now they have metastases. Is that the cancer that has progressed now? Is this a different cancer with a different molecular blueprint? And so trying to get a new biopsy is always important. And then, of course, increasing approvals, increasing complexity in approvals and treatment options. It's really hard to keep up with as well for anybody. So liquid biopsies do have an advantage. We talked about these. They're all different. So some of them will measure DNA, RNA, some proteins and exosomes, and some of them will even test whole cells. But really, the potential is huge, right? So they're looking now, and there's a lot of data coming out to even detecting cancer early. So tumor DNA may have a huge advantage over some of these other screening tests that are imperfect. Not to say that this is perfect either, but it could just be an adjunct to detecting cancer early and then, of course, aiding precision cancer treatment, which is what we want. And then monitoring treatment response with tumor DNA. Right now, we use imaging scans, and they're good, but they have their risks. They have, of course, a radiation risk, and the contrast has a nephrotoxicity potential. Some people can't get the scan that they need because of renal failure, and insurance doesn't want to pay for the PET scan. So there's so many challenges, and another way to monitor disease response would be really helpful. But there are limitations, right? Most cancer types lack biomarkers. I mean, this may be great in my lung cancer patient that has that EGFR mutation that I'm now measuring in the blood to see if the patient's responding. But what if I have a patient with squamous cell non-small cell lung cancer that doesn't have an identified driver mutation at all, and now it's really hard. How can I follow that patient with liquid biopsy? So it may not apply certainly to everyone. And then does ctDNA in blood truly represent the DNA in the actual tumor? Does it really represent all areas that are actively growing or having resistance? We don't know. Certain mutations that we capture in the blood may not be driver mutations at all. They may be what we call passenger mutations. And do we base our treatment decisions based on that? So, and again, they haven't been proven prospectively to improve patient survival, the liquid biopsies, but I think there's a lot of data looking retrospectively, and really we extrapolate from the next-gen sequencing data that we presume that testing and acting on these biopsies would improve survival. These are some of the liquid biopsy tests, and I think I went over the different types with circulating tumor cells, the DNA, the RNA, the exosomes, and there's also liquid biopsy tests that are done based on the indication of the tumor, although I think that really agnostic liquid biopsy tests are what's most common now, where you just do the test and it will run a whole sequence of 300 to 400 genes that are most commonly found in solid tumors. I'm going to skip that. So this is sort of the whole plethora that I found, at least this is a couple years old again, of your testing options. The Foundation 1 CDX is a DNA-based test, 324 genes. The MSK Impact, which is specific only to Memorial Sloan Kettering, unfortunately, is 468. And then there's the Oncomine DX, there's Caris. The options are many. The Guardant, of course, is the liquid test. Foundation also has a liquid test. And there's multiple companion diagnostic tests as well that are for one specific mutation that we look for. And we generally think about those when we're talking about breast cancer and we're looking at the PIK3CA alteration, and there's a companion diagnostic test that we can run with that. Although it seems silly to run one test when really you need the full panel to make the appropriate treatment decisions for your patients. But these are just some of the options, and you can see, as good as it is to have options, it can become quite messy if you're used to ordering tests from multiple different vendors and trying to put it all together. So there's a lot of potential. I think that we're really early on in the liquid biopsy world. I think that we're looking now to use liquid biopsies in combination with the solid tumor NGS biopsies to look for concordance and to really validate and also maybe get some of the testing results earlier than the next-gen sequencing will get for us, because the liquid biopsy turnaround time is, I think, somewhere from 5 to 7 days as opposed to 14 days, which may not seem like a lot, but to a patient waiting for tests, it's a big deal. It's not to mention the time that you need once you identify a target to order that drug, which will then get shipped to the patient. That's another few weeks, right? So every day is important to these patients. And so, of course, at metastatic diagnosis, we know that there's a role for liquid biopsy, especially for non-small cell lung cancers, and this is something that is approved and now, thank goodness, is paid for. But after subsequent lines of therapy, I think it's important to consider doing these tests as there's progression of disease in these patients. You're looking to look for resistance mutations and so forth. Now, the only exception would be if you're really thinking there's a change in histology, and there is obviously that exception. EGFR-driven non-small cell lung cancers can develop into rapidly growing small cell malignancies, and the only way to identify that would be a tissue biopsy at that time. So can't win everything, but these are, screening. Again, early detection for cancer would be a wonderful addition to the current screening that we have, and the current lung cancer screening is utilized anywhere from 4 to 6% in the United States, right, of eligible patients. So anything would help. Response to therapy, we talked about, and then drug testing, personalized therapeutics for obviously clinical trials, and molecular assays and genotyping, and then identifying targets that have tumor heterogeneity. So I'm going to end with sort of the challenges that I personally have in incorporating genomic testing in clinical practice. And of course, we know that there's a cost factor. They're expensive, and different insurance coverage depending on the patient. We don't truly know. There's no transparency at the time of ordering a test what the patient might or might not get charged. It's not until they call the patient and their patients will say, no, I can't pay the $200 copay, cancel my garden testing. And the physician finds out 2 weeks later that this was not actually done. Not to mention we could have helped them with that copay. But there's a lot of layers involved in payments that are not transparent. There's delay in results. We talked about delay in treatment. Delay in results often happen as these tests are typically not ordered by the pulmonologist or the thoracic surgeon, not until the patient reaches the medical oncologist, and which may be 4, 6, 8 weeks later, that the initiation of this testing is begun, which then causes delay in procurement of the tissue and all of that. So there's a lot of delay that is meaningful in these patients. These are not slow-growing malignancies, and so these are clinically meaningful. And then the not enough tissue material to test, that's an ongoing issue that we work with our local pulmonologists or surgeons. If they're resecting the tumor, we should have plenty. But if it's just a biopsy, really the pulmonologists have come a long way in making sure that their tissue sampling is as adequate as possible. And too many options of platforms. Really, it's like, it's paralyzing. You don't know which decision to make. I'd rather somebody just make any one of them because any one of those testing platforms is still better than not testing. And the results being difficult to interpret. Several times you'll have a report with multiple different potential mutations and which one is the driver mutation. Having access to the genomicist who can really work through, if it's the variant allele frequency to identify that this may be a germline alteration versus not, all of that stuff should be very, very easy and shouldn't take a long time. And I think they're getting much better at it, but it really should be part of the report as well. So that you don't have to reach out or email someone or call someone to get an answer, which should be evident on that 35-page report. And then really, this is my Achilles heel. There's no integration into their electronic medical record system. There are patients who have sequential testing, multiple sources of testing, and I'm literally typing it in manually. And that is just mistake driven. I mean, there's so many mistakes when you manually type these results in. There are mutations you might have ignored a year earlier that now may be clinically relevant because I didn't feel like typing all that stuff in there. But who goes back to the original report all the time? We don't. And so we end up relying on our EMR abstraction year upon year upon year, and it's really they need to, and they're working on it. I know they're working on integrating into Epic and some other EMRs, but that's something that needs to happen. The idea that there's no reflex testing across most institutions for non-small cell lung cancers. Not only do we need testing in advanced stage now, but because of early adjuvant data that's already established for EGFR, we need to start doing testing early on. Stage 1A, 2B, and so really a lot of testing needs to be done. There's so much paperwork involved. And there's no real ASCO guidelines on appropriate patients to test and retest, really, for all other malignancies. I know there's some NCCN guidelines, but ASCO really, I feel like, needs to put out really good guidelines on genomic testing and liquid biopsies in the near future to give us better guides. And then commercial tests are not always accepted in clinical trials. I have enrolled I've tried to